Stein Emil, and he's not a stranger to most of you, so I don't have to say a lot. We're happy to have him here for a year as a visiting fellow. Country perspective.
Okay, thank you, Theo. So, I will tell you a little bit about Norwegian burden of disease study that has just been started. I'll say some of that project, then give you a brief introduction to mortality, morbidity, and risk factors in Norway, and focus on additional data sources that can be useful for future updates of the global burden of disease projects, from registries, from cohorts, from surveys. And I'll tell you a little bit about legislation and regulations of health data, and speak about models for collaboration between Norway in particular, but in general between a country and IHME, and some try to conclude. I work for the Norwegian Institute of Public Health, and this is a large institute with a staff of 1,100 people in Oslo and Bergen, directly under the Ministry of Health. And the institute has 6 divisions: environmental medicine, epidemiology, forensic medicine and drug abuse research, infectious disease control, mental health, and a public relation and resource division. And it's part of the mandate of the Norwegian Institute of Public Health to provide a summary of the population's and risk factors that determines the population's health, and also to inform the population about causes of health problems and diseases. So I show you this from the United Nations just to show you where Norway and Nordic countries are placed between Greenland and Russia. And the combined population of the Nordic countries is 26 million, with 5 million, around 5 million on each of Denmark, Sweden, and Finland, and then close to 10 million in Sweden, and 30,000 on Iceland, I think. And before I go on, I will just come with a brief personal reflection, partly on my own, looking back on my own career. I think that most and much epidemiologic research in the past 30-40 years has focused on relative risks for disease and what is called etiologic research that aims to identify causes of disease. And this is well and important, but in my opinion it's gone too far at the expense of descriptive epidemiology, and too little focus on estimation of absolute risks of disease and attempts to estimate the proportion of disease and mortality that are caused by risk factors. And I think a strong counterforce to this deviation of epidemiology has been the GBD project that was started, as you know, in the early 1990s under the World Bank. Then it had its WHO era, and now GBD 2010 and 13 are firmly placed here in Seattle at IHME. Then I will say a little about Norway. Let's say, yeah. But first, before GBD 2010, there were done about 40 national burden of disease studies. And many of these were done in collaboration with WHO and with the aid of the WHO toolkit, and at the local level. Now we are in the post-GBD 2010 era, because this year has marked a revolution in global health statistics with the publication of country results that were released by IHME in March, and with detailed data sets in September. This has never been done before, and it sort of sets the activities at the country level in a new perspective, because now there are burden of disease analysis for each country in Seattle already. So what do we do then in each country? I show this slide just to show you that among the Nordic countries, as far as I know, this type of studies were done in Denmark and Sweden, but not in Norway or Finland or Iceland, as far as I know. And there were two reports in 2006. And the Swedish one were done by using the WHO toolkit, and the Danish, they did it in their own way. After the publication of the GBD 210 in the Lancet, there has been quite a lot of publicity about the global burden of disease study in Norway. And this was a little bit before Chris Murray visited Norway in late January of this year. This is an op-ed piece in the most important Norwegian newspaper under the title Obesity, the New Hunger. And it was quite a well-written synopsis of the GBD 210. And we have been preparing a Norwegian burden of disease project for a while now, and actually now we have started. It is in an early phase at the Norwegian Institute of Public Health, and but we established a burden of disease team in September when one demographer and one health economist started, and we are hiring an epidemiologist at the moment. And we have initiated collaboration with IHME, and we aim to develop that collaboration further. And also there are good news for the project in the sense that we are on the government budget proposal for 2014 with a substantial amount, and this is combined with an initiative to evaluate public health measures in Norway. And one of the selling points of the burden of disease project has been that we want to do a national study, of course, but also sub-national, both on geography and also on social inequality measures that I will come back to. Then I will give a very brief overview of health, disease, and risk factors in Norway. And I like to start with this graph that we put in a Norwegian Institute of Public Health report a couple of years ago. And this shows life expectancy at birth for men in blue and women in red from 1846 until 2012. And we see that between 1850 and 1900, the life expectancy in Norway was between 45 and 50 years, with quite a lot of fluctuation. And this corresponds to the countries in the world of today with the lowest life expectancy. And then we had a dramatic increase from around 1900 until the end of the Second World War, just marked by a drop during the Spanish flu in 1918 and for men during the Second World War. I think this is a very strong and steep increase in life expectancy. And actually, in the early, yeah?
Why do the difference between men and women increase based on the developed country pattern, life expectancy in developed country between men and women have to be close now?
Yeah, the question was about the difference in life expectancy between men and women, and I can comment on that shortly, actually, but just say that after the Second World War, around 1950, Norway had the highest life expectancy in the world for both men and women between 1950 and 1955. But then something happened. And we see that there was a widening of the difference. And for men, it completely stagnated and even were reversed between 1955, and it did not increase again before in the late 1970s. And I think the answer to the question is smoking. At that time, men picked up smoking much more than women. And also the diet was rich in unhealthy fat. There was trans fat, and there was a lot of saturated fat. And especially Norway had a high consumption of trans fat that was from marine oils, hydrogenated marine oils from herring and whale. And that could explain some of this strong effect of the tobacco epidemic, maybe in combination with unhealthy fat, that there was synergy. Then we see that when we come to the 1980s and late 1990s, then especially for men, the increase in life expectancy pick up again, and there is a narrowing of the difference in life expectancy between men and women. And now, but Norway is no longer on the top like we were in the early 1950s. Now Norway is now between 12 and 14 in rank place for life expectancy. Of course, we understand a little bit more if we look at causes of death and not only total mortality that is reflected in the life expectancy. And this is a graph we made for the same report. What we are showing here, What we are showing here is 4 major causes of death: accidents and violence, cancer, other diseases, and cardiovascular diseases. And we show it for men in the upper panel, for women in the lower panel. To the left, all ages. In the middle, deaths before age 70. And then at right, deaths at age 70 or above. And I think the most dramatic thing we see here is apparent in men under 70. The dramatic epidemic of cardiovascular mortality, with a very strong increase from 1950 to 1970, then a slight drop until 1990, and then a just as dramatic drop until this day. This is also seen in older men and in all ages combined. It is in women. We don't have a strong increase. It's visible in older women, but not in women, younger women, where there is a decrease throughout the period from 1950 to 2010. I think, so this is the big cause of death trend for over the past 60 years in Norway, and also many other Western countries. I think what surprises most people when they see this graph is that there are relatively small changes in cancer mortality compared to cardiovascular mortality. Look, for example, for women, cancer mortality in women, all ages combined, is almost flat from 1950 to 2010. And the same thing, accidents and violence, almost flat. There is a decrease also in other diseases than cardiovascular diseases, but less than for cardiovascular. Yes?
Would you see a decline in terms of rates? I suppose these are numbers of deaths.
These are age standardized rates.
Oh, rates. Okay.
And also for men, we see more changes in cancer mortality than in women, but not as dramatic changes as we see for cardiovascular. There is an increase here that is largely due to smoking and lung cancer, but at the same time we had a very clear drop in mortality from gastric cancer. That was the major cause of cancer death in 1950. We also see that there is a considerable decrease in deaths from accidents and violence, particularly in men below 70 years of age.
A lot less in comparison to other high countries.
Yeah. And to view these numbers in a slight perspective of the other Nordic countries, I will show you this graph that shows mortality between 40 and 70 years of age, what I call middle-age mortality, and I like to focus on this age span because it captures lifestyle-related mortality relatively well. And what we see here, it's slightly, the graph is marked by the colors of the flag, so we can see. So this is Finland in blue and white, where we see there was a very high mortality in 1950 for men. And this is done by multiple decrement life table methodology. So here we estimate the proportion of men who die between 40 and 70 years. So actually in 1950, 50% of Finnish men died between 40 and 70 years. And we see that in 1950, the mortality was also highest in Finnish women. And we see that we have steep decreases in middle-age mortality death risk in all the countries. And for women, they converge. And actually, it's quite interesting that Finnish women, in contrast to Finnish men, they reach the same low level as the other Nordic countries, whereas the Finnish men, together with Danish men, they remain high compared to Norway, Sweden, and Iceland. And we also see very markedly here the phenomena of increased mortality of Danish women that started around 1975. And actually there was a reversal of the downward trend that did not cease until 1990. And from then on, there has been a steep decrease in the mortality of Danish women, but they are still high above the other Nordic countries. What is also interesting is that this is not explained by cardiovascular mortality, because we see the women, they converge at a very low level. We see exactly the same pattern for all 5 Nordic countries for cardiovascular mortality trends during the 60 years period. The only exception is that Finnish men, they are shifted upwards, but the curve, epidemic curve, is the same. So basically, where we find the differences is in cancer mortality and in patterns for non-cancer, non-cardiovascular mortality, where we see that Danish women, they deviate from the rest of the Nordic. Both Danish women and Danish men deviate from the rest of the Nordic countries. Accidents and violence are not very important in this age range, but we see that Finnish men are above the other 4 countries. And I think I won't have time to go into explaining all of these, but I think many of these, the trends we see here, can be explained by lifestyle. Then when it comes to describing morbidity and epidemiology of non-fatal diseases in Norway, I think, as far as no one has presented a good comprehensive overview before GBD 2010 released the Norway data and the country data this year. So this is picked out of IHME's Norway country profile, and it shows for Norway years lived with disability, the morbidity by age for 2010. It shows the dominance of mental and behavioral disorders in the young adult population, and then we see the musculoskeletal disorders that dominate in the latter part of adult age, and we also see diabetes coming up after age 40. And I think this is also quite similar to many other countries. And this risk factor graph has become very popular in Norway, and because we have never produced this ourselves. I think the only of these risk factors, the only calculations that have been done is for smoking and some for alcohol. But and we see that dietary risks are on top, then smoking, and then the metabolic risk factors, but also substantial mortality from alcohol use and drug use, and some to occupational risks. And like I said, GBD 210 is the first comprehensive analysis of mortality, morbidity, and risk factors combined, presented for Norway ever. And in general, I find the results very reasonable. I have compared smoking attributable mortality estimates with Norwegian estimates, and they agree very well. I think there are only a few hundred deaths in difference between the 2010 estimates. Mortality, of course, agrees well with Norway's own cause of death data. One surprise to me is that morbidity, or years lived with disability estimates, are relatively high for Norway compared to the other Nordic countries in Western Europe. And areas where the morbidity estimates are high are mental disorders, musculoskeletal disorders, and diabetes. And unsurprisingly and sadly, because this is well known in Norway, Norway ranks very high on burden of illicit drug use, especially mortality burden. And this is just to show you what I meant by high estimates for morbidity in Norway compared to, I picked these numbers from country results. The gray column is Western Europe. The green is Nordic countries except Norway. Then we have Norway, and then each other Nordic country individually. And up here we have deaths. We see that the age standardized death rate is very similar for Norway than other Nordic countries and Western Europe. And we have lower mortality than Finland and Denmark, and higher mortality than Sweden and Iceland. That agrees well with what I presented before. The same is true for years of life lost. Actually, Norway is a little below the other Nordic countries. That is, again, a little below Western Europe. And again, we are below particularly Denmark and Finland. But then comes years lived with disability. And there is very little variation between the Nordic countries. And the Nordic countries, except Norway, has the same level as the rest of Western Europe. But Norway sticks up a little bit, about 10% above. So this is something that we will look what happens with in the future iterations of GBD. Then I will discuss some additional data sources, registries, cohorts, surveys. And I will not focus on the same things that The Economist did in this issue that had a long article on the Nordic countries earlier this year. But first I will just say a little bit about what is common for the Nordic countries, and that is that we have a well-developed social security net. We have high standard of living, well-running economies, low levels of income inequality, extensive public sector, universal health care and social benefits. At the moment, we have moderate unemployment, high female participation in workforce, and low and no-cost higher education. But a less known thing about, or common feature about the Nordic countries is that we have very similar health registry system. And if we look, for example, at the nationwide cancer registries that were started in 1943 in Denmark, and all the other Nordic countries, do not have Iceland on this list, but Finland, Norway, and Sweden followed up and established nationwide cancer registries already before 1960. And the same thing with cause of death registries. Actually, we have cause of death registry data longer back in time, but this is the year from which we have individual records electronically available today. So that, again, that is 43 in Denmark and 69 in Finland. We also have something that is not very common in other parts of the world, and that is medical birth registries. And actually, Norway was the first country with a medical birth registry in 1967, and then they were established in Sweden and Denmark, and then in Finland in 1987. And the background for the medical birth registries was the thalidomide catastrophe, with an epidemic of serious congenital malformations. And the Nordic countries wanted to set up surveillance systems that, for example, could pick up that type of problem. You also see that all these 4 Nordic countries, they now have hospital discharge registries, patient registries. All hospitalizations are registered centrally. And Denmark, Finland, and Sweden had these registries running already in the 1960s. Norway was late with the patient registry, and it was established with personal identifiers only as late as 2008. Then all the countries also have prescription registries that, for example, in Norway, all prescriptions that are picked up in the pharmacy are registered on the individual. About 30 million prescriptions per year in Norway, I think. This is just to give a brief impression of the volume of the Norwegian patient registry data. Like I said, we have 5 million inhabitants. We have registered in a single year 6.2 million contacts with somatic, that is non-mental hospitals, and that includes inpatient, day patients, but also hospital outpatients or polyclinical consultations. We also have registration of mental health services, both inpatient, outpatient, and substance abuse institutions, and also consultations with mental health and somatic specialists with reimbursement agreements with the government. This is a graph of the number of live births in Norway from 1846, when we have data, until recently, and we see that there are born between 40,000 and 70,000 over these years. I have marked one period here, starting in 1967, green, and that is from this time on, not only the birth is registered, but also information about both the mother, the father, the child, diseases of the mother, drug use in the mother, smoking, vitamins, birth weight, length of gestation, vital status, mode of delivery, birth weight, and all diagnoses on the newborn and procedures performed during delivery and after birth with the child. Yeah.
much after birth? So do you know outcomes, say, of preterm deliveries, 5 years down the road, 10 years down the road?
It was a question about how long are children followed up by the medical birth registry. There is no routine follow-up, but by linkage studies, there have been these, for example, premature babies have been followed up to adult age. And for example, you can look at educational attainment and reimbursement from the disability system and where also diagnostic information is available on these children during their lifetime. So there was a quite nice study published in New England Journal of Medicine a couple of years back with this type of follow-up study. The medical birth registry contains at the moment about 2.5 million births, data on 1.2 million mothers and over 1 million fathers, and many children born in 67 or later, they are now in the registry both as a baby and later as a mother or father. And they can be there several times. And all of this can be linked. And this is a rich resource for important epidemiologic research. So this was just a brief description of some of the important national health registries. This is the complete list of national health registries. And one problem with the system as we have it today is that these are located in different institutions. So, for example, the 10 first, they are run by the Norwegian Institute of Public Health. Then the Cancer Registry and the Newborn Screening Registry, they are run by one of the health trusts, by the hospital system. Then we have the Norwegian Patient Registry, which is the largest information of morbidity information, which is run by the Directorate of Health. And we have actually a very interesting registry of Norwegian Armed Forces Medical Services that is run by the Defense Department. We also, within the hospital system, have an increasingly rich list of national quality registries. And this list is developing from year to year. And I will not go into detail here, but I can, for example, one of the first of these quality registries that were established were the arthroplasty registries. So, for example, all hip replacements have been registered since 1987. And there have been many important studies on failure of hip replacements, when you can have long follow-up and you measure the failure as a operation and where it's necessary to replace the original replacement. There are also several well-run quality registries of particular cancer diagnosis. For example, the lung cancer registry for gynecological cancer, and colorectal cancer registries. Of course, to tie all of this together, the national population registries, which exist in all the Nordic countries, are important, and with the management of the person number, or in Norway it's called the birth number, which uniquely identifies each individual. And I must say that in the recent years, this system has been under some pressure because of immigration and also asylum seekers, and they do not enter into the person number system immediately, and there are problems with some segments of the population to link. Also, we have important socioeconomic data registries. income, education, occupation, country of birth is registered on the individual level and kept. These data are kept by Statistics Norway. And we have an important database in the Norwegian Labour and Welfare Services, which, for example, registers sickness absence and disability pensions with diagnostic information. And there is also a new source that is now emerging on primary health care reimbursement data. And I will show you here the first time these data were published were by Statistics Norway in their stat bank just a couple of months ago, where based on data from reimbursement claims from primary care physicians, the number of consultations for respiratory infections, local pain, inflammation, back problems, muscle pain, aches, joint arthritis, mental disorder, and so on, was reported by age and sex for the year 2012, I think. One problem with this data is that there is a large lump of so-called other diagnoses, and it's very important to find out if these are unspecified conditions or other specified, and it's probably a combination of that, but that is a clue to know more about this group, to see the usefulness of these data for example, burden of disease work. When I see this slide, I know I'm going to switch and maybe speed up a little bit. This is an introduction to the richness of cohort data in Norway. This is a study we did a couple of years ago where we followed 66,000 men and women from the mid-1970s to 2009, and we estimated mortality between 40 and 70 years by a combination of BMI and smoking habits. And we see if we contrast, this is for men, this is for women, we see that if we have a normal weight, never smoker, 10% of men die between 40 and 70 years. Which contrasts with 53% of heavy smoking obese men die between 40 and 70 years. Then we are back to the mortality level we had in Finland just after the Second World War. The same series of cohorts participated in the global burden of metabolic risk factors.
On that previous graph, you haven't put in the category 25 to
No, it's
29, because there's some controversy whether you actually get lower mortality at below 25 between who are considered overweight and not yet obese. So it'd be interesting to see that.
Yeah, I can show you the data. That was on the dose response curve of BMI. In these Lancet papers, and that also was fed into GBD 2010, Norway participated, but somewhat variable. We had 286,000 participants in the BMI analysis, none in the cholesterol analysis for some reason. It was not lack of data, but probably due to different ownership of different parts of the data set and cohorts. Actually, we do have established between 1970 and 2005, we have data on BMI, history of diabetes, physical activity, smoking, cholesterol, blood pressure on about 635 to 50,000 individuals that have been linked to the cause of death registry and other registries. So this is an important source, especially for estimating joint effects of these very central risk factors. And I think results of joint effects of these risk factors is sparse in the literature and needed to improve burden estimates. We also have a very large mother and child cohort that is run by the Norwegian Institute of Public Health. Actually, we have now recruited, and recruitment was finished in 2008, 107,000 pregnancies from 90,000 mothers, and 70,000 of the fathers participated. And there are more than 500,000 questionnaires returned and more than 300,000 blood samples from 250,000 people. This is closed, but publications and follow-up continues. We also have data in surveys. Statistics Norway and Statistics Norway Stat Bank is an important source. For example, a living conditions survey, where there is data on self-reported BMI, tobacco, disease, health complaints. The same stat bank contains primary care consultations. The Directorate of Health, in collaboration with the University of Oslo, has diet surveys on adults, on infants and adolescents. And there are additional data that have not been used so far, as I know, from the Norwegian Institute for Alcohol and Drug Research on use of tobacco, alcohol, and illicit drug use. I will not go into detail on legislation and regulation, but just mention that the first law regulating health and other data was the Statistics Act from 1989, which regulates statistics production at the Central Bureau of Statistics. After 2000, we have had a series of revisions of laws, or new laws that regulates use of health data. And particularly important is the Health Registry Act, that has a very detailed regulation of the running and use for research of data from the cause of death registry, the medical birth registry, cancer registry, prescription registry, and Norwegian patient registry. And since the Health Research Act in 2008, approval is needed for all research on non-anonymous data from these registries from a regional committee for medical and health research ethics. And this system runs well for some project, but it is our experience that projects that link many registries and plan to operate over many years, it can be a complex and time-consuming process to get approval for that type of larger projects. Then I will say a little bit about how IHME and a country collaborates or could collaborate. And as you know, collaboration is ongoing now between IHME and China, UK, Sweden, Australia, Mexico, Saudi Arabia, and with Norway. And this is at the national level to improve and add data to GBD 2013. Survey data, cohort data, surveillance data that has not been available in the scientific literature reported internationally. And then there are also subnational components of this collaboration, and the subnational collaboration can be divided in two parts, I think. What is ongoing at the moment with, for example, China and UK is geographic estimates for regions or smaller geographic regions. What we plan to do for Norway and can be done easily in principle in the Nordic countries is that we can also do subnational analysis by level of education, by income level, because we have this information available at the individual level. And I think that will enrich both our own statistics and also the international project. On the next, on the next slide, I have what I would almost call a wish list. I think if you think about the collaboration between IHME and a country, there is transfer of data and knowledge from the country to IHME. IHME has a lot of knowledge and methods and software and standards and training to offer to countries. And I think, for example, the workshop, a 2-week workshop in Greece this year was very valuable for those who participated. I think it's also important for IHME to think that standards are important. And standards, they should hopefully be stable. For example, the course list, I think, is very valuable. And it's the more countries that start to use it, the better, because it's more detailed than previous lists and will ease collaboration. Also, reporting standards for hospital data would be very useful. I think the covariate database that has been established here is a very rich resource for the whole world. There is also a need for documentation of sources for country-specific research work, which I know is ongoing here at the moment. And also, in addition to uncertainty estimates for each country, I think it's also important to know what results were estimated within in-country data, informed by region or super-region. I also think that it would be very useful to have software available, not only in Seattle, but also at the country level. For example, redistribution tool could, and I think has been promised to be made available in the future. It would be useful if we could have a country version of this mod to estimate the morbidity. And also, I think many countries would appreciate in some way to have access to the tools used here for calculation of attributable risk. And I think a balance between what the groups that are established in countries to produce burden of disease estimates and the activities there, and the activities central at IHME, where we find this balance is very important for assuring the long-term success of the GBD collaboration and work. And so we need to work together to establish a knowledge base also outside IHME, an expert group at the country level, but maybe also at somewhere in between the global and the country level. And I think now it's time to wrap up. I think this is what we lack, and now I mean Norway. At the moment, we lack a system for regular updating of risk factor prevalence and morbidity monitoring. We need to update nationally representative data on the central risk factors, and we need to improve and update data on occurrence of major sources of disability like low back pain, anxiety, depression, and so on. And this needs to be done not every year, but regularly, and estimates must be made by age and sex and be nationally representative. And this is important not only for Norway. Many, many countries, also high-income countries, lack a system for that. And I was happy when there was an initiative within the European Union to establish a European health examination survey. And this was successful with its pilot phase, but I'm a little bit uncertain if this is going to be turned into an ongoing system at the moment. It has met resistance within the system recently, but we should continue to push for something like this to happen in all countries. And that was more or less what I had to say. I think the GBD framework is very important because we can place national data on diseases and risks in a demographic and public health and global perspective. And when we all use the same framework, it enhances comparability between countries, which is very useful. And like I said, we should establish risk factor and mobility monitoring and refine and update burden estimates. And the first round of this is ongoing now with the GBD 2013, and I also, to the degree I have a Nordic audience here, I hope to be able to establish a collaboration with Denmark, Sweden, Finland, and Iceland. Thank you.
This is very topical. We're trying to find out these establishments and collaboration with the mall with Norway for an extended period of time with us. Very helpful. Thinking about this to set up these
Stein, Emil, thank you very much. One curiosity, when showing the results from GBD to officers, health officers from developing countries, in general, the reaction I have seen is that they feel that this is marvelous. They have never seen this information altogether. So I'm curious, when you are dealing with 5-star data like the one we have, what is the reaction of the people from the Ministry of Norway when they see this?
Yeah, the question was about how is the reaction with the health authorities in Norway when they see the GBD results. And I think, compared to maybe what they see in what we call the developing world, but I think when it comes to health statistics, all countries are developing countries. We have no high-income health information systems that are well run and can present comprehensive analysis of a country's burden of disease. So I think they are just as startled as the ones you are talking about. And actually they have never seen, they have asked for this attributable deaths to risk factors. They've asked for that list for 10, 15 years, the Ministry of Health, but nobody has given it to them before GDP became.
More a comment. I think, well, we know you are going to be here working hard on developing the national Norwegian Border of Disease Historia. I think it will be interesting to document very well all the challenges that you face, even tracking the time that it takes for some things, because I think it's going to be like a very useful example of what it takes to do a study like this with all the type of information that we have. So I think it's something that an added value that you can have on our state, besides how you do with also.
I agree with that comment that we should keep track of the process in the collaboration between Norway, as an example, and IHME. And I think that's valuable for all partners. And it is my experience that some components of this type of work is relatively slow in Norway, because it can take a long time to put the systems together and get all the necessary approvals to do large-scale data analysis. Because we have the data, but they are not in one place. They need to be put together. Yeah?
To what extent do you think it's necessary to have individual identifiers in your national registries to make them suitable for GBD, for instance? Many other countries don't have that, even Western European countries, because the sentiment is that it's a violation of privacy, for instance.
Yeah, and that sentiment is also growing in Norway. So that's why these processes often are slowed down somewhat. But I think to have personal identifier is very helpful if you want to do, for example, a burden of disease study stratified by socioeconomic status. Because then you need mortality estimates by education, you need morbidity estimates by education, and you also need risk factor prevalence estimates by education. And if we can extract those data from registries, we can actually produce those estimates stratified by linkage. And if not, they would have to be collected from scratch, I think, in other countries. But
even for simple things like to make it possible that and useful, we're not interested in numbers of admissions. So a few months ago, how many people have been affected, and so can
Yeah, that was the question. Was to what extent does Norway track health expenditure data? And I do not know for certain too much about that. But we have a DRG system, and the hospital are reimbursed by activity. And actually, that's one of the main tasks of the hospital discharge registry, to feed the numbers into the reimbursement systems. Like, the numbers are available. I don't know how easy it is to get them out, but I think it is tracked within the hospital system.